What about the patient who is not fit for chemo and just gets radiation? Are you giving them durvalumab after 6 weeks of radiation?
I am not. I think that that's a different patient population from what was enrolled in the trial, and I think when you're not a candidate for chemoradiation, I think you're, for the most part, treating with a palliative intent, and I've not done durvalumab.
How about you? I haven't actually had a patient come up yet, so it hasn't.
I've been reluctant, although what I do see sometimes happening is sort of dialing down the chemo. And so
the hurdle's lowered again.
We're sort of, and we're not even doing that. Sometimes things like that would be done for sort of a reimbursement issue. This, I think it's more to treat me rather than the patient, that we sort of have stuck with what the validated approach is, at least somewhat. So I think that there's no great data there. We do have studies looking at, after SBRT, for instance, looking at durvalumab, and I think those are interesting studies. So I've been reluctant, but I wouldn't say never necessarily.
So that's an interesting case you brought up. So if you started a patient on concurrent chemoradiation and you've dropped chemo halfway through, finished radiation, you would give that patient durvalumab at that point?
I would.
Okay.
I think I would.
Okay.
I know when we've done it, yes, and part of it is, again, this is what the patients want.
Yes.
Now, some of those patients will go on to have pneumonitis and other problems, so it's not that it's always a great decision for the individual patient. But it's very hard after you've talked to a patient about this regimen, and they're sort of to then say, well, since we dropped, after a couple of cycles, we're also going to drop the immunotherapy you were so excited about before.
Yeah, and often you're dropping the chemo for different reasons. They're cytopenic, their counts, they're just are not there. But at least there was someone you thought could tolerate it to begin with. So what about those patients that we thought were borderline resectable, and whose surgeons would say, give some neoadjuvant concurrent chemoradiation and then we can assess for surgery? Has the Pacific data changed how you're managing those patients? And are your pulmonologists now biopsying more lymph nodes? It used to be that our pulmonologist would go in and just biopsy one N2 node and say it's stage 3. I'm seeing our pulmonologists are actually biopsying multiple N2 nodes. Has Pacific changed who's become a surgical candidate at your institution?
I would say maybe. So there are some clear cases in both directions. So somebody who has contralateral and mediastinal involvement, that's somebody we're not going to be sending to surgery. Someone who has single station, microscopic or very low burden disease, that's still somebody who I would go with a very traditional approach of going to surgery. On the other hand, we all have in our tumor boards these discussions all the time. The bulky multi-station mediastinal lymphadenopathy, the patients with several lymph nodes, including a subcarinal lymph node. These poor prognostic features that have generally done quite poorly. And this is in the backdrop, of course, of the largest study ever looking at the comparison between the two, not showing a benefit. Now, I know there are subset analyses and things like that people have looked at with that. But yes, I think that whereas before I was more inclined to let the sort of surgeon duke it out with everyone else, and this sort of idea of the benefit of the doubt that the surgeon always wants to there, it has made me a little more aggressive to say, in an era of chemoimmunotherapy along with radiation, that it is a reasonable treatment option, particularly in these people who I don't anticipate good surgical outcomes. But I'm interested in if that's done for either of the two of you.
We were pretty conservative that we generally took the people with a single station disease to the chemotherapy induction followed by surgical resection. We didn't do a lot of chemoradiation induction. And I think I'm fortunate to work at a place with good surgeons where we generally get median stenoscopies, and we know our single stations are really single stations. So I don't think it's changed our practice patterns, but we were pretty firm beforehand.
Our surgeons are the same, and we actually were doing more neoadjuvant chemo as opposed to concurrent chemo in those potentially surgical patients. What about a patient who gets neoadjuvant chemo, radiation, and surgery? You giving them durvalumab, or you're saying you're done?
I'm saying that you're done. I think that's a different patient population.
Yeah. So speaking of surgical patients, we saw some data as well at AACR this year, and then some updates of ASCO looking at neoadjuvant checkpoint inhibitor followed by resection. The data was published by Patrick Ford in New England Journal of Medicine, showing a nice pathological response rate in the 40 to 50% range. Where do you think this data is going? Are we ready to think about neoadjuvant immune checkpoint inhibitor or chemo immune checkpoint inhibitor for resectable patients?
I think this is the next step. I think, well, first of all, it's a small study, so I think it's a proof of concept more than a practice right now. But I think this is very appealing to me because you can get the biopsy, do the immunotherapy, then get the resection and really have a pathological assessment of the response, and it looks very promising. I think we're going to probably need some refinements into who's best for single-agent immunotherapy with the neoadjuvant approach, or who needs the chemoimmunotherapy, or who needs just to go right to surgery. Because I think some of the early-stage patients, I'm not sure if there's a lot of benefit to induction approach. It's more for the higher stage or the borderline resectable patients where we need to get that response to get them to surgery.
Are you doing anything different, Eddie?
So a lot of, in the early stage disease, we have an excellent surgeon, Jay Lee, who's the co-chair of, this co-surgical chair of the LCMC3. So we've been part of the atezolizumab study. I think for me, the big question in terms of the data, I think there's beautiful scientific data in the Ford study. The concern that I have for the long term, and studies are going to address this, is do the responses that we're seeing pathologically mean something down the road? And in the end, obviously, these are not mouse experiments. We're not trying to get rid of a tumor for the sake of having the tumor be smaller and to show a nice figure. I think that from a proof of concept, this was a tremendous work, but I think that it is going to be exciting to see in the upcoming larger studies whether or not the outcomes that we see correlate with what we really care about. Is our patients going to be living longer?
Yeah, and absolutely. You know, one of the things that I think also makes me think about these studies is they're looking at TMB, and can a surgical patient, should we be making them wait a month to get the TMB data back to get a checkpoint inhibitor? Yeah. And then also, what do you do if there's not a pathological response? Do you say, okay, now we're going to give you 4 cycles of a platinum doublet just because it wasn't as good? So I think there's a lot there of what we're going to see.